Okay, good afternoon, good morning, and good evening to our distinguished speakers, partners, and audience who are following us on this live stream event on our UNAIDS Facebook page, Ace Data Hub, and the Foreign Correspondent Club of Thailand, the FCCT Facebook page. I welcome you all to this regional webinar entitled Briefing on the Global Guidance on Validation of Elimination of Mother-to-Child Transmission of HIV, Syphilis, and Hepatitis B, and the launch of the new EMTCT webpage on Ace Data Hub website. My name is Dr. Ye Shui. I'm Technical Officer and Regional Focal Point for EMTCT in UNAIDS Asia Pacific Regional Office. Today, I'm co-moderating this webinar with my colleagues, Dr. Linvi Lee, WHO Regional Office for Western Pacific, Dr. Selva Eliani, UNICEF East Asia and Pacific Regional Office, Dr. Bibi Rawari, WHO Regional Office for Southeast Asia, and Mr. Desire Razi, the UNAIDS Asia Pacific Regional Office. During this live stream event, you will hear more from our esteemed speakers on the new global guidance on EMTCT and country experience, achievement, and lesson learned in progressing towards the elimination agenda. I also invite all our respected audience to share your views, comments, and questions in the live event on the Facebook page, and you will make sure that your questions are answered by the respected speakers. Without further ado, I will hand it over to my colleague Desire, who will be moderating the session for the opening remark by our agency heads and representatives. Desire, the floor is yours.
Thank you very much, Dr. Yeyu. Good afternoon, good evening, colleagues, depending on where you are watching from. We have 4 speakers lined up to give us some opening remarks today. At this point, I would like to invite our first speaker, Dr. Suman Rijau, Director, Communicable Diseases, World Health Organization, Regional Office for Southeast Asia. Over to you, Dr. Suman.
Thank you. A very good afternoon and good evening. The Regional Director of UNAIDS Asia and Pacific, the Regional Advisor for Health and HIV, UNICEF East Asia and Pacific, Focal Person for EMTCT at WHO HQ, Acting Coordinator of HIV, Hepatitis and STI at WHO WIPRO, faculties, national program managers, and representatives from the communities and distinguished participants. I welcome you all to this Asia Pacific regional webinar on triple EMTCT of HIV, Hep syphilis, and Hepatitis B, being co-organized by UNICEF, UNAIDS, and WHO, CRO, and WIPRO. At the outset, I extend my appreciation to all countries, partners, and communities for their efforts towards EMTCT of HIV and syphilis, and now hepatitis B. As you are aware, 3 countries in the Southeast Asia region, Thailand, Maldives, and Sri Lanka, have been validated for achieving the EMTCT of HIV and syphilis, and they are maintaining their status. I would like to congratulate to these countries and all the partners who have also been a motivation for other countries in the region to expedite this effort in this direction. As you will hear from Dr. Morko, WHO has updated global guidelines for EMTCT of HIV and syphilis and has also included hepatitis B. I'm happy to share that these guidelines for EMTCT of hepatitis B were recently piloted. Triple elimination now available. Countries in the region can initiate discussions for validation of their triple EMTCT status. I hope the discussions on these guidelines today will be a benefit to you all. In this regard, while accelerating efforts in screening pregnant women, mothers for HIV, syphilis, and hepatitis B, and linking to treatments when required, it is also important to emphasize on the need for fully vaccinating all infants for hepatitis B, including the timely birth doses. Countries also need to include additional measures, such as the use of antivirals for pregnant women diagnosed with chronic hepatitis B to prevent transmission. In addition, strengthening PHC approaches and including services under a UHC framework, specific service adaptations like use of dual HIV syphilis combo test kits, increasing and timely antenatal checkups can not only bring in synergy, but also improve the efficiency. In conclusion, I would like to highlight the importance of ensuring integrated service delivery towards achieving these shared goals of not only the EMTCT, but also improving maternal and child health and related ones as aligned with the Sustainable Development Goals. CRO is fully committed to support the countries in the region on this endeavor as part of one of the 8 flagships of our regional director. Thank you.
Thank you very much, Dr. Suman, for those remarks. May I now invite Dr. Toidu Islam, Acting Coordinator, HIV, Hepatitis, and STI, WHO Regional Office for the Western Pacific. Over to you, Dr. Toidu.
Thank you very much, Mr. Rodzi. Distinguished colleagues, Regional Director, UNAIDS Regional Office, Asia and the Pacific. Regional Advisor for Health and HIV, UNICEF East Asia and Pacific Regional Office. And also the Director, Communicable Disease, World Health Organization Regional Office for Southeast Asia. And all the participants and all the viewers of this webinar session. I'm really honored and pleased to be part of this opening ceremony. I'd like to welcome all to this important meeting. I'm very pleased for the Western Pacific region to take part in the effort towards eliminating mother-to-child transmission of HIV, syphilis, and hepatitis B. We have made substantial progress in the last decade in the region towards the triple elimination of these diseases by building solid foundation for HIV testing, antiretroviral coverage, hepatitis B vaccination, and syphilis testing. Yet, we will need to move at a faster pace to achieve the desired future where children are born free of HIV, free of syphilis and hepatitis in all countries by 2030. It will be particularly important to reach those vulnerable populations that are often missed by the current health system. And to do this in cooperation with civil society and using local level innovation. The updates to the EMTCT guidelines will be able to guide us towards achieving elimination targets and increase the number of countries successfully validated for EMTCT. The regional office for the Western Pacific will work with partners to adapt these new guidelines with a focus on reaching geographically difficult population like smaller island countries and socially disadvantaged population. And to work not only with country system, but also with those who need the services. It will be critical to monitor progress as we scale up. And the EMTCT webpage is a welcome initiative for countries to monitor their progress and learn from other countries. We hope that the website will be helpful and used extensively by countries. Thank you very much, and I wish all a very good meeting. Thank you.
Thank you very much, Dr. Toidu. May I now call upon Dr. Basil Rodriguez, Regional Advisor for Health and HIV, UNICEF East Asia and Pacific Regional Office. Over to you, Dr. Basil.
Thank you, and good afternoon. I extend my thanks to the government representatives, national AIDS programs, UN sister agencies, civil society communities, and other participants. The HIV epidemic in its 5th decade is compounded by the global COVID pandemic, which has stretched healthcare systems and constrained access to life-saving services. Simultaneously, poverty reduction gains are in reverse. Abuse and mental health issues on the rise, and increasing risks of HIV infection to children and women. With the Global AIDS strategy, new goals have been set. The trajectory on HIV/AIDS epidemic among children, women, and adolescents indicate that with partnership and dedicated efforts, the end of AIDS among children and adolescents can be achieved by 2025. However, unless joint efforts are accelerated to resolve inequalities driving the HIV epidemic, which are now exacerbated by COVID-19, more children will be infected with HIV and more children will lose their fight against AIDS. To address the inequalities in access to treatment among children and adolescents, countries need to integrate HIV into primary healthcare and strengthen health systems, adopting innovative technologies for improved access and quality of HIV service delivery. As part of the efforts towards achieving and maintaining elimination of mother-to-child transmission of HIV, syphilis, and viral hepatitis, WHO, UNICEF, and UNAIDS regional teams have collaborated with countries across the Asia-Pacific region to convene this important webinar. Improving disaggregated data collection and analysis will help partners identify key inequalities and gaps, indicating where greatest gains can be achieved for maternal, child, and adolescent HIV health. The launch of newly developed webpage will highlight key data related to triple elimination, built on the existing HIV and AIDS data hub for the Asia-Pacific website, up-to-date analysis reports, technical guidelines, and publications, as well as the Asia-Pacific success, lessons learned, and challenges in EMTCT validation and triple elimination will be available for use. This webinar will also provide a brief on the new global guidance on the process for validation of elimination of mother-to-child transmission of HIV, syphilis, and hepatitis B, and present countries experiences moving towards elimination and achieving validation of elimination of mother-to-child transmission. Finally, UNICEF is committed to work with partners on the new political declaration on HIV and AIDS, especially scaling up implementation of evidence-based prevention efforts for adolescents and children, while placing those communities affected by HIV at the center of our efforts. Thank you for the opportunity to share these few words at this important meeting, and wish you a good day. Thank you.
Thank you very much, Dr. Basil. Last but not least, I would like to give the floor to Mr. Tofik Bakali, Regional Director, UNAIDS Regional Office, Asia and the Pacific. Over to you, Mr. Tofik.
Thank you so much, Desire. Dear colleagues, I feel honored to join this great gathering here. I would like to acknowledge Dr. Suman, Dr. Tawhidul Islam, Dr. Basil, and the representatives from countries and the community who have joined us. It's a pleasure and an honor to meet you again in this event to share the updated information on the global guidance on validation of elimination of mother-to-child transmission of HIV, syphilis, and hepatitis B, as well as the launch of the new EMTCT website that is hosted on the AIDS Data Hub website, which belongs to all of us. It's a representation of great partnerships among all stakeholders towards this very important component of the global AIDS strategy on ending AIDS as a global health threat, and particularly in achieving the 2025 targets. Our region has a mixed picture in terms of progress towards the elimination agenda. We have outstanding examples in the region of countries that have achieved validation certificate for EMTCT of HIV and syphilis, such as Thailand, Malaysia, Maldives, and Sri Lanka. But we have also some countries who are getting very close to achieve that elimination, and others who are a little bit behind. They face a number of challenges. Some countries in our region see the PMTCT coverage is less than 30%. Our region is still lagging behind the global trend, and only 57% of pregnant mothers living with HIV received antiretroviral therapy to prevent mother-to-child transmission of HIV. We made some progress in this region, but I am sure we can do better. And we need to strengthen our collective efforts to make the AIDS-free generation a reality. Elimination of mother-to-child transmission is a full, comprehensive reflection in true terms of leaving no one behind. And that means we need to find solutions of ensuring that anybody who needs the services has access to them, eliminating the stigma and discrimination barriers, strengthening the services, strengthening the systems for preventing services, bringing in community, and all those elements provide determine the core of what the global AIDS strategy is about. Achieving that goal within the EMTCT tells us that we can achieve it for the global AIDS response in the region. In this region, we are launching the new webpage that is dedicated for the EMTCT on our AIDS Data Hub website. The idea of having this is basically to document, to compile the knowledge that has been achieved in many countries, gathered in many countries, and make it available for success. How solutions have been established and implemented, allowing for some countries to achieve excellent results with regard to the elimination of mother-to-child transmission. And what are the learnings from the challenges faced by a number of countries? This is a resource for everyone to access and use. And this is a documentation of our success and our journey toward achieving the global AIDS strategy targets. Finally, I would like to thank all partners, community, national programs, and particularly our co-sponsors, regional offices with whom we have an excellent collaboration in this region: WHO WIPRO, WHO CRO, UNICEF EPRO, for their unwavering collaboration in this common agenda and various aspects to our work together to end AIDS in the Asia-Pacific region, on EMTCT and much beyond. Thank you so much for the opportunity to join this esteemed gathering, and I look forward to hearing the country examples and presentation. Over to you, Desire. Thank you.
Thank you very much, Tawfiq. Great appreciation to all the four speakers for the opening remarks. Now I hand over the microphone back to Dr. Yeyu.
Thank you, Desire. And now, on behalf of UNAIDS, WHO, and UNICEF regional offices, we are very proud to launch the new EMTCT webpage on the AIDS Data Hub website. Don't blink now, you will see the launch. Okay, thanks to all the audience and speakers and who are joining the this webinar. Yeah, I am again. Now I'm going to walk through the new EMTCT webpage that we just launched. So I'm going to share the screen right now. I hope you can see my screen. So as I mentioned, this new webpage is hosted on the AIDS Data Hub website, which some of you may have already familiar with. So this new webpage, as you can see, has the 7 main features in its main page. You can see that, and I will go through one by one just to get you some familiarity with the website. So on the home page, you will see the brief note on the initiative of the EMTCT Triple Elimination Framework and the regional framework for the elimination of mother-to-child transmission of HIV, syphilis, and hepatitis B in Asia and the Pacific. Go down a little bit, then you will see the highlighted resources, that reference material that we uploaded on our website for the public good. So next to the page is that where you can see the targets, indicators, and frameworks and policy that are related to the EMTCT. Moving to the next is the third tab, where you can see the estimated disease burden or HIV, syphilis, and hepatitis B. The indicators are organized by country in the table, and the table is downloadable in Excel format and PDF format as well. Below the table, you can see the PMTCT cascade, where you can see the PMTCT cascade organized by the country and also for the Asia Pacific region. So this graphic, and you can see the full screen view on the on your computer. If you click on this little window icon on the left on the right lower corner, and you can see as a full screen view on your computer. You can switch to the switch by the countries by going through each of the country, where you can see a lot of data there. Then, if you want to download the data, there is the download arrow on the right lower corner, the same close to the window icon, and then you can see that dialog box open. If you click on the dialog box, and then there, if you click on the cross tab, you can download the data in the Excel format as you wish. So next step is about the basic maternal and child health indicators that we combine all maternal and child health indicator by country, and this is also the table, and you can download as well. So next to that is the triple elimination EMTCT data for the 3 diseases, and the data are organized is as the impact and the process indicator, as many of you will already be familiar with. On the upper table, you will see the EMTCT impact indicator or data for the Asia Pacific country, and the lower table holds the process indicator, as you can see in that. So this table is kind of folded to each other, and you can download the data in the Excel format as well. So next to this tab is the is my favorite tab, is the country galleries, where we showcase the countries that have achieved the EMTCT validation in our region. I'm proud to present that in our region, we have 4 countries, Thailand, Malaysia, Maldives, and Sri Lanka, that have achieved the EMTCT validation for HIV and syphilis. So last but not least, there is a publication and resource tab. If you go to there, you can see that we stores and showcases the latest report, technical guidelines, and the publications for the public asset. For example, you can see the newest report from Cambodia, where there is where they have the mock review of the elimination of mother-to-child transmission of HIV and syphilis in Cambodia. So it is very impressive work done by the Cambodia team. It is a joint effort of WHO, UNICEF, and UNAIDS ourselves, under the commendable leadership of the National Center for the HIV and AIDS and Dermatology and STI, NCHART, and the National Maternal and Child Health Center, NMCAC. So I recommend countries who are planning to go through the EMTCT validation to have a look on this report and take advantage of the mock review process and experience that are generously shared by the Cambodia team. So with this, I conclude my walkthrough session, and I invite my colleagues, Dr. Lin V, to take the floor to moderate the next section. Lin, the floor is yours.
Very much, Yu. Hello, warm greetings to everyone. My name is Lindy Lei, and I am with the HIV, hepatitis, and STI team at the WHO Western Pacific Regional Office. So for the first presentation, it is my pleasure to introduce my colleague, Dr. Morkar Newman. She's a medical officer with the treatment and care team at WHO headquarters. And she leads the work on EMTCT and women's health and global HIV, hepatitis, and STI programs. She has extensive experience in communicable disease prevention and control, including HIV and STI, and in particular, EMTCT in high-burden countries. She's also an expert on reproductive, maternal, neonatal, and child health. So I would like to now invite her to introduce the updated guidelines on the criteria and processes for validation on the elimination of mother-to-child transmission for HIV, syphilis, and hepatitis B. Over to you, Dr. Newman.
Thank you very much, Lynn, and good afternoon, good morning, good evening to everyone, wherever you are. If you could please put up the slides, thank you. We're just going to take a quick run through the new guidance for validation of elimination of mother-to-child transmission of HIV, syphilis, and hepatitis B virus. Are the slides coming up?
Not yet.
Okay. But just to say that these are key updates that we are going to speak through, and that, as you all know, we have gone through quite a process since 2010. And 2010 is when PAHO, the region that first started elimination, established the goal for 2015. After that, EMTCT guidance came up, and that was the first edition of this document which we are about to speak to. And there was a global consultation on the tools and agreement on what should be used. And as you all know, Cuba was the first country which was validated. In 2017, however, we realized that we had to have a new version of the book because there was the high burden countries who are unable to meet these very strict criteria of impact of 50 cases per 100,000 live births. So there was an introduction of what is called path to elimination, where countries have the ability to be recognized as having been at least progressed so much that they are not quite there, but there has been good progress in those countries. In addition, right, thank you. If it could go straight to the third slide. So the third slide shows where we are now. Thank you so much. So as I was saying, in 2017, we had the second edition, which included the path to elimination. We'll speak a little bit more on that as we go further on. But as of 2021, we now have 15 countries who have been validated, among which are the 4 which have been already spoken about. But then interestingly, we had the first high burden country, Botswana, then validated as being on the silver tier on the path to elimination. Next slide, please. So what exactly have we done? We have revised the book by, first of all, changing the title. So now it's not dealing only with validation of HIV and syphilis, it's now HIV, syphilis, and hepatitis B virus. Now, because of the change in title, it's now the third version rather than the third edition. For that, we had to integrate hepatitis B into the criteria and processes. We also updated criteria and processes for HIV and syphilis. We aligned with all WHO guidance, which has changed since 2017. And then very importantly, we strengthened the human rights, gender equality, and community engagement. So all this went into the new version. Next slide. Just spend a little time on this next slide where we will look, next slide, please, where we'll look at the criteria. And you'll realize, and I'm sure you're all quite familiar, HIV and syphilis have very similar impact and process criteria in that the same 50 cases per 100,000 live births for incidence, and then EMTCT rate for HIV of less than 2% in not breastfeeding or less than 5% in breastfeeding populations. The difference here, as you can see with the orange square, is that hepatitis has a different impact criteria, which is the less than 0.1 prevalence of hepatitis B surface antigens in any population less than 5 years. There's additional criteria for low prevalence countries, which is the EMTCT rate. Here we talk about universal birth dose, and where a country has more than 90% coverage of the hepatitis B3 vaccine, as well as the hepatitis birth dose, that is the criteria, the process criteria. However, if the country does not have universal birth dose or has targeted birth dose, slightly different in that we have included that you must have a 95% coverage of maternal hepatitis B surface antigen testing to ensure that you are actually identifying the women who will need the intervention. And also you should have more than 50% coverage with antivirals for those eligible. And this is for validation. Next slide, please. The next slide just takes us quickly through the path to elimination. We won't spend too much time here, but you realize that the prevalence requirements, which are at the top row, are that the country must have an HIV prevalence of more than 2%, syphilis prevalence of more than 1%, and in hepatitis B, the prevalence of greater than 1% among the same population of 5-year-olds and or the general population. Now, it's important that we consider that these are the requirements if a country is going to go for path to elimination. The impact targets you find are still quite high in that the countries still need to have the low EMTCT rates, but the case rate here has been increased to 750 cases per 100,000 live births, and that's the same for HIV and syphilis. For hepatitis, you find that we have reduced to 90% the process targets, and that's also for the HIV and syphilis. But for hepatitis B, same 90%, but there must be implementation of timely birth dose. Next slide. The policy at least must exist. For silver, the difference is that we now have 500 as the incident rate for HIV and syphilis, and then still 90% coverage for the process targets. However, there's an additional more than 50% coverage of the birth dose, which must be exist. And then availability of the antenatal testing in the public sector. The next slide then shows us the gold, where it's very similar to the validation, but then we find that the next slide, please, gold. Yes, here we increase the coverage to more than 95%. And then if you look at hepatitis B, you find that it's 90% coverage of the infant vaccination, timely birth dose, and at least 30% coverage of the testing in the antenatal sector. Next slide, please. So the other key revisions are that we now have a step-by-step guidance for meaningful engagement of women. And this is very important to ensure that human rights, gender equality, and community engagement are well integrated in the whole process. That's right from planning to implementation of the assessment. We have a glossary. Now, with countries with small numbers, we find that we needed further guidance, which is included, and more detailed information of spectrum, the WHO congenital syphilis tool, and the calculation of impact indicators. There's also a reduction in detail of all the governance-related information, as this has been moved to a separate document, the governance guidance. Next slide, please. So the next is that in the low-performing subnational administrative unit, we insist that we should have more information on migrants and displaced persons who have the lowest coverage or access to services. Now, there's a revision of maintenance of validation time intervals. We used to do it every 2 years, it's now every 3 years for standard countries and 5 years for small population, low burden countries. In addition, we have decentralization of the global functions to the regional structures and inclusion of reporting of the validation components provided by all health sectors, which means public and non-public. There's also a revision of the laboratory quality standards, including more specifications on external quality assurance for validation. Next slide, please. Ongoing, we are looking forward to having the second version of the governance guidance. Hope this will come out in June 22. And it serves alongside this new document. So it aligns the processes. And then as we said, all the governance details have been removed from the Orange Book and put in this governance document to avoid ambiguity. We've also clarified language, and there's consistent and concise reviews for each country's at the level which is specified. Now, we are revising the assessment tools, and this is to address all the updates, including updates in norms and standards, hepatitis B assessments, and there's going to be a guide so we can do in a standard way the interpretation of the assessment results for the human rights, gender equality, and community engagement tool. Next slide. So finally, we'll look a bit at where we are and the projections. And not all countries are here, but UNAIDS has this information and is able to give you your estimates for your country, so you see exactly where you fit. So for a case rate of less than 50 cases per 100,000 live births, if you look at the red line down the middle, you'll find that the countries to the left are those who have less than 50 cases. However, the case rates, as you know, for the blue line, that shows the 50. For the gold line, that shows where we have the gold tier. The silver line, all those below are the silver tier. And then the bronze line gives those who fall into the bronze tier. So you find that Thailand is right here at the bottom, and it fits very well into where the country is when it comes to elimination. It's very helpful to see where you are if you are able to have this graph with your country inserted in it. Next slide, please. Also for syphilis, we find that there has been some progress, but you see that for CRO and for WIPRO, there have been decreases in the case congenital syphilis rates, which is really good. But screening coverage is also going up for the two regions, and the treatment coverage is not so high, but also going up. So you find that this is much better than other regions where you have, unfortunately, case rates going up, such as in EMRO. Next slide, please. And then lastly, looking at hepatitis B virus, as you know, the coverage of the birth dose is not where we want it to be, but you can see clearly in the map at the top right, the darker the blue, the higher the coverage. And you'll find that the good news is the health story that the hepatitis B cases have fallen below 1% in children. And the SDG target is this less than 1% prevalence in less than 5-year-olds. So globally, this is happening. But if you look at the regions, it's not the same picture. Yellow is pre-vaccination and green is post-vaccination. And you find that the estimated hepatitis B prevalence among children has decreased very widely, where post-vaccination, it shows quite clearly where vaccination is being done. Next slide, please. So that gives us where we are. Next slide, please. And what we would like to encourage is that all countries consider this, because the targets may be ambitious, but they can be achieved. And the integrated person-centered healthcare, as well as health system strengthening, is essential for this. And countries really should be applying for triple elimination validation, because even if you're not quite there, you'll find that the application gives you the opportunity to ensure that you're moving in the right direction. And even when you apply for dual or single, you still have to report on the other two conditions in the validation assessment. So a key message is that countries should apply or should consider applying for triple validation. So thank you.
Thank you very much, Dr. Newman, for your informative presentation on the validation process. It's helpful to know that there is a path for elimination so that countries with high burden can be recognized at different levels for their accomplishments in reducing EMTCT rates. So for those interested in learning more, the Orange Book can be found online at the WHO website. I'd like to now turn the floor over to my colleague from UNICEF, Dr. Salwa, to moderate the next session on to hear country experiences. Thank you very much again.
Good afternoon, good evening, everyone. Thank you, Dr. Len. It is my pleasure to be introducing the next 6 presenters, guest presenters in this session. Our first presenter is, it's my pleasure to introduce her, Dr. Wang Eling. She is a chief physician and director of the Maternal Health Department of the National Center for Women and Children's Health at China CDC. She is mainly engaged in maternal health care, prevention of mother-to-child transmission of HIV, syphilis, and hepatitis B. As a team leader, she's responsible for National Maternal Health Management, PMTCT program planning, technical guidance, training, supervision, and evaluation, and other technical support. So we'd like to welcome Dr. Wang Eli. Over to you. Thank you very much. Go ahead, Dr. Aling, we hear you.
Okay, now can you, my screen is clear?
Yes, it is. Thank you.
Okay, thanks so much. It's my honor to be here to have an opportunity to give an introduction to elimination mother-to-child transmission of HIV, syphilis, and hepatitis B in China. Thanks so much for the organizers' invitation. As we know, China has higher disease burden on hepatitis B. There are the data in 2008. At that time, we estimate how much infants on the risk of mother-to-child transmission of HIV, syphilis, and hepatitis B. So from 2010, based on the PMTCT of HIV network, we start to integrate the syphilis and hepatitis B EMTCT prevention service to existing HIV prevention system. I will introduce the introduction on the strategies of PMCT in China. From 2010, the financial support was 800 million per year RMB. The areas covered 1/3 counties in China. From 2015, we expanded to the whole country. The financial support increased to the 1 million per year. From 2017, we started the pilots for elimination of PMTCT program in Zhejiang, Yunnan, Guangdong, and Zhejiang and Beijing, supported by UNICEF. The second strategy is providing integrated service and enhance service quality. At the beginning of PMTCT program, we integrated all related service into routine maternal and children's health. Take mother-to-child transmission of HIV as an example. The main intervention is testing and counseling RV drugs and safe delivery and infant feedings. All pregnant women get the routine service. They also get different service from each woman depending on their disease, with HIV, with syphilis, or with hepatitis B. They get the maternal care, delivery care, and the baby care at the same with other pregnant women and infants. Just because they have HIV, syphilis, or hepatitis B, they get additional service. Pregnant women, with them like the anemia, we think this the integrated service could reduce the stigma and discrimination. We also have a data collection system. For this system, we not only could get the data of epidemic of infection of pregnant women and their infants, but we also could identify the problems and the weakness with the data triangulation. We could do several activities to enhance the quality of the service, such as infection disease report system, annual report of maternal and children system, EPI data collection system, and other related data. The third strategy is carry out extensive social mobilization and promote multi-sector cooperation for pregnant women and their infants. There are three kinds of organization have direct relations. MCH in China, MCH hospitals, general hospitals, and the CDC and the Disease Control Center. They also have a relationship with the community. All this happened in the society, and several sections and are involved in the implementation of intervention of mother-to-child transmission. For example, civil affairs department, education sector, and so on. The last strength is in China. For we want to pay attention to the key barriers and bottlenecks and provide equality. At the beginning of the program, we pay more attention on the mode summary, team capacity, and the service coverage. As this step are implemented, we are paying more attention on the key barriers and bottlenecks. Now we pay more attention to hepatitis B and also have the community participations. So this is the for more details. There are some main activities on EMTCT program from 2017. In 2017, we did gap analysis on EMTCT in China. We used compare with the WHO tools and the China situation. The gap analysis done on national level and provincial level. In 2017, analyzed for launch pilot areas and evaluation on the areas of the EMTCT of HIV to China to know the result of intervention of mother-to-child transmission rate of hepatitis B. In 2018, one main work is training on anti-stigma and discrimination in hospital. We invited experts from Thailand to help us. In 2019, we invited the domestic and the foreign experts join sites supervision. We want to summarize and experience the EMTCT program and expand it to the whole country. So in China, we went through pilot areas, during which we located and prevented our elimination strategies. From this year, we will start the validation on the provincial level. Compared with WHO targets, we still have some indicators have not achieved. To main objective of EMTCT, we will pay more attention on the improved weight points. There are four main activities. One is giving different guidance to different categories of areas. For Liangshan of Sichuan, we will focus on the capacity building. For Guangdong, we will focus on the migrant pregnant women. For young people, we will focus on the prevention infection and avoid unwanted pregnancies. The second point is improving community participation. From 2017, we try our best to invite the community to join into our EMTCT areas. We also applied for the special fund to support NGOs to participate in MTCT transmission. In recent years, the situation is getting better. Strengthen supervision and quality control and assessing progress and effective successfully will be the two priority areas for us. We will, in these 2 or 3 years, we want to pay more attention on these 2 points. So the goal and the goals of EMTCT and the validation, especially the new guideline, is very clear for us. We will try our best to let our children far away from HIV, syphilis, and hepatitis B. Thanks again for UNAIDS. We also want, for this conference, we also want to look forward to get information and experience from share from other countries. Thank you.
Thank you very much, Dr. Wang Aling, for the wonderful presentation, and thank you for keeping to time, even though there was so much information for you to share. We would like to remind our participants to post their questions in the chat box. And I would also like to remind our speakers to kindly keep to the time because we do have many more guest speakers. So the next speaker is Dr. Shabani Rajan. Please, over to you. Thank you very much. Dr. Shobani, you are on mute. Can you please unmute yourself? Thank you.
All esteemed technocrats from the UN agencies, WHO, UNICEF, UNAIDS, country representatives, delegates, community members, thanks for having this presentation from India in terms of the current status of EMTCT, of mother-to-child transmission of HIV. I represent the HIV/AIDS prevention and control program, and hence my presentation is probably going to be heavy on the HIV part. So as you may be aware, in the Indian program, the AIDS control program goes through phases, and we are presently in the 5th phase of the AIDS control program from a period of 2021 to 26, wherein our goal is ending the AIDS epidemic as a public health threat by 2030. And as far as our objectives are concerned for 25-26, it is to reduce annual HIV infections and AIDS-related deaths by 80%.
Apologies, Dr. Shobani, apologies. Can you please make your show slideshow as a slide, full screen, please? And I apologize.
Is that working?
Yes, now it's working. Sorry, and I
Okay,
apologize. Just a quick intro to Dr. Shobani Rajani is a public health professional in the field of HIV/AIDS with 2 decades of experience in the government of India, working in the National AIDS Control Program since 2008 and leading several components. Currently, she manages the community-led targeted interventions, HIV counseling and testing, and ST management, and also is the Deputy Director General for the Global Funds at the Ministry of Health. Again, a very warm welcome. Dr. Shobani, over to you, and apologize.
Thank you so much. To resume, I was talking about the 2025-26 NACP 5 goals, wherein we have specifically indicated reduction of annual new HIV infections and AIDS-related death by 80%, and also to promote universal access to quality STI, RTI services to at-risk and vulnerable populations. So definitely 2 of the disease control programs, that is the STIs and HIV, the AIDS control program is definitely working towards it. Now, I'd like to draw your attention to the 3rd point, which is in terms of the HIV/AIDS prevention and control, where we are talking of 95% of the pregnant and breastfeeding women living with HIV should have suppressed viral loads. And this strategy that India is adopting is adding this 1 prong to the 4 prongs of EMTCT, wherein the first prong talks of primary prevention of HIV, focused on those who are yet to be infected. The second prong is focused on those women who already know their status and are perhaps already on ERT in terms of preventing unintended pregnancies among this group. The third prong being prevention of mother-to-child transmission by making sure that all the pregnant women get access to HIV and syphilis testing during their pregnancy, and adequate management through this prong 4 of providing care, support, and treatment to the HIV infected mother and child. Now, this prong 5 that we are talking about is most relevant to our discussions today as we talk of validation, because the strategic information measuring the progress on EMTCT through the divisions of surveillance and epidemiology, monitoring, and research and innovations, which are part of the AIDS control program, this will take due importance. The phase 5 of the AIDS control program, the cornerstones are prioritization. And as you can see from the map, which talks of the data that we have drilled down to the district level of the EMTCT needs. So we need to prioritize on these red and perhaps orange districts to make sure that we reach our goal of EMTCT. And along with that, we need to leverage technology. We have to make sure that we optimize and repurpose the existing workers within the program We build in partnerships with all the stakeholders, the multilaterals, the implementing agencies, as well as the private sector, and do our interventions in a gender sensitive and through a community-led approach. So the focus areas for elimination of mother-to-child transmission include campaigns on EMTCT, where we increase the awareness for both the screening as well as for access to treatment, making family planning and SRH services available for women living with HIV/AIDS, so that we can leverage the prong 2, testing of all pregnant women, providing antiretroviral treatment for all the HIV positive pregnant women, and ensuring that they retain and adhere to the ART towards viral load suppression. And all these pregnant women that we find who are infected with HIV are required to, their babies are required to take the dose of nevirapine, as well as go ahead for early infant diagnosis and treatment. So in terms of the strategic information on EMTCT under NACP phase 5, we need to measure our antenatal coverage, which presently stands at 92%. The HIV testing as well as syphilis testing among the pregnant women. The HIV testing presently stands at 78%. And the ART coverage, which presently stands at 53%. And viral load suppression is also something that we need to build in terms of our data. With respect to retention on ART among the HIV positive pregnant women, we need to measure those who are on ART prior to their current pregnancy, as well as those who are initiated on ART during current pregnancy. In India, we do have a proportion of women who are diagnosed only when they come into the labor room and then are initiated on ART. So ensuring that we reduce the dropout and we ensure EID for these postnatal mothers who are detected is also very important. Breastfeeding in India, at least, is not unheard of. It's actually the norm. So we need to see what is the impact of breastfeeding on the babies and their transmission of HIV. And we need to measure the fertility patterns. While the presentation that I have made may not really express our present readiness towards, the validation for EMTCT, but you all are aware that India is a very large country and there are 3 crore or 30 million pregnancies. And the approach that we need to at this point of time take up, especially since we are beginning with our 5th phase, is to strategize and prioritize and focus our interventions for EMTCT for at least HIV and syphilis together under the AIDS control program, as well as engage with the hepatitis control program for the dialogue on hepatitis. So I would like to end with these remarks, and we look forward to collaborating with all the stakeholders towards this. Thank you.
Thank you very much, Dr. Shubhani, for this wonderful presentation. And again, I remind the participants to put their questions in the chat box. And I remind our guest speakers to keep to time. And our next guest speaker is Dr. Anita Suleiman, who is leading the National HIV, STI, Hepatitis C program at Ministry of Health in Malaysia, and has championed the country validation for elimination of mother-to-child transmission of HIV and syphilis. She has more than 2 decades of experience in HIV, ranging from providing primary healthcare services to crafting innovative strategic plans, guidelines, and national investment case. Her latest effort is combating stigma and discrimination against people living with HIV at government healthcare. Welcome, and over to you, Dr. Anita.
Thank you, Madam Chairwoman. Thank you again for inviting Malaysia to present the Malaysia experience in achieving elimination. A little bit on the country demographic. As you know, Malaysia has 32 million population with majority Muslims, about 61%, and the rest are Buddhists and Christian and the rest. And if you can see that the HIV epidemic in this country, Malaysia is still a country with having a concentrated HIV epidemic with prevalence more than 5% among main key populations that are the MSM, the people who inject drugs, transgender population and female sex workers, and while the prevalence among general population is still below 1%. It is important to note that in Malaysia, we have dual care system, which means the health systems are provided both by public and private. And the primary healthcare is the main thrust of healthcare system in Malaysia that provide MCH services, outpatient and dental services. And PMTCT has started in Malaysia in 1997, 1998, and as we know that Malaysia PMTCT is being provided as a fully integrated program into the MCH services at primary care level, and this program entails giving HIV tests, syphilis tests, treatment, prophylaxis, patient monitoring through point of care tests for CD4 and viral load, and also combined care. A little bit on the current policy of PMTCT in Malaysia. We practice voluntary opt-out HIV syphilis tests at all government health facilities as well as at private as well. And as for treatment policy for pregnant women, for those who are positive HIV will be given option B plus, which means treatment with antiretroviral continued for life, whereas for syphilis, treatment with adequate penicillin regimen. And whereas for infants exposed to HIV infected mother will be given prophylaxis with syrup Exact-T 6 weeks or single dose nevirapine at birth and Exact-T 6 weeks, whereas whenever indicated for syphilis, the infant will be given IV benzathine penicillin. All HIV exposed baby will subjected to HIV DNA PCR within 2 months of birth, and for VDRL and TPHA at birth, 3 months, 6 months, and 12-month old. And for HIV specifically, the mothers are being given options to feed the baby with infant formula feeding, and these are given free to those babies. Okay, a little bit on the process that has brought the country into elimination certification. It took us about 2 years, the efforts to reach to validation of EMTCT. And these 2 years, we have been working on the validation of preparing for validation without any additional resources. And finally, middle of 2018, Malaysia was certified to have eliminated vertical transmission of HIV and syphilis. And we are supposed to undergo revalidation 2020, but unfortunately, because of this COVID-19 pandemic that has struck most of the countries, the validation is being postponed to this year. A bit on the achievements of the outcome indicator, like I think the previous presenters has already mentioned. We can see that for the MCCT rate for HIV, I share with you the comparison between the programmatic and spectrum of MCCT rate HIV in Malaysia from 2012 to 2020. Now, looking at the programmatic data, Malaysia has shown a reduction or has already achieved elimination since 2013 onwards. However, to compare, I think as requirement for elimination certification, we need to show the less than 2% true spectrum data. So only in 2018, Malaysia has touched below 2% of vertical transmission rate for HIV through spectrum data. Whereas for infection rates for HIV and congenital syphilis, if you can see that Malaysia has been maintaining below 50 per 100,000 live births for both HIV and syphilis. But you can see this is important to note that for congenital syphilis, there has been a gradual increase since 2018 onwards. There is a reason why we are seeing an increasing number with infected with congenital syphilis. Number one, being most important reason is because of strengthening of our MNE reporting system for congenital syphilis, especially on the reporting of syphilitic stillbirth. Now, previous year, syphilitic stillbirth was not reported to the Ministry of Health surveillance system, but from 2018 onwards, syphilitic stillbirth is being reported. So therefore, you can see that increase of congenital syphilis that got reported in our surveillance system. On top of that, the reason why you can see the increase is because of the change in the case definition for congenital syphilis. Previous 2017 and earlier, the congenital syphilis reported in our surveillance system are mainly definitive diagnosis or lab diagnosis. However, from 2018 onwards, we have changed the case definition to match the WHO surveillance case definitions. Therefore, we are detecting more and more cases. Nevertheless, those numbers are still way below 50 per 100,000 live birth. Now, if you can see, again, the increasing in congenital syphilis reported through our surveillance system in infant, it is in line with the increasing trend of antenatal mother detected syphilis positive from 2017 onwards. Right, so it is tally with the findings that I showed just now with the previous graph. There has been an increase in numbers of antenatal mothers detected positive syphilis. Unlike the HIV counterpart, we can see that the seroconversions of antenatal mothers are beginning to stabilize. There is a reason why to explain the increase in trend of seroconversion of syphilis among antenatal mothers. I'll show later on if we have the time. Now that is the outcome indicators, but as for process indicators, you can see that the antenatal coverage, the HIV and syphilis testing coverage and ART plus treatment, adequate treatment syphilis for antenatal mothers who are exposed to the disease has been above 95% from 2015 to 2020. What we have done or what has changed since the validation that we achieved in 2018, a lot of efforts have been put in place to strengthen wherever weakness that we found during the validation process, and as well as recommended by the Global Validation Advisory Committee. Number one is that we have revised the national guideline for EMTCT, syphilis, and HIV in 2020 that emphasize on the importance of early testing and treatment adherence, especially U equal to U, and also we strengthen on the delivery options, infant feeding options to based on the latest guideline for HIV management. And again, in this new guideline, we introduced the use of rapid diagnostic tests for syphilis, although the use of rapid test diagnostic syphilis is not universal to all antenatal mothers due to request by the expert group. We still need to retain the RPR, but however, there is role for RDT syphilis, especially on those late bookers, mother who come late in gestation period, hard to reach population, especially those who stays at the interior, especially among the aborigines, and high risk population, mother, unwed mother. So there are a whole list of criteria, those mother whom we advise to test syphilis using rapid diagnostic test. Upon receiving a reactive test, the mother should be given treatment the same day while waiting for the TPHA or the confirmatory. So this is a way to ensure that all mothers especially the high-risk mother, will get treatment, will get adequate treatment, which is at least one dose using benzathine penicillin. So this is something that we have changed, and also again we emphasize on the need to report stillbirth those mothers with VDRL positive. And again, last but not least, in this revised treatment guideline, we also emphasize on the importance of SRHR, the sexual reproductive health rights for women living with HIV, when we also emphasize on the eliminating stigma discrimination, especially among women living with HIV. And in the same year, we have established a national committee for PMTCT, HIV and syphilis. And this committee consists of various expertise, among others are the ONG specialists, pediatricians, PIDS ID, neonatologists, and also public health specialists. This national committee has an important task to play, not only itself implementation issues and looking at the or strengthening the national guideline, but also review each and every congenital syphilis cases and to decide whether it really fits in the surveillance definition of WHO and get counted as congenital syphilis in the country. So in 2020, we expand the EQA, and also we update the HIV testing algorithm to include the RDT for syphilis, that is national testing algorithm. And most importantly, in 2021, last year, the new revised national guideline for PMTCT syphilis gets circulated. That it is a directive by the Director General of Health in Malaysia, gets circulated to all government and private. And following that, in 2020, we had a huge nationwide training that was participated by more than 6,000 healthcare workers throughout the country, both private and public sector. You can see here, I share with you the brochures that we distributed to all through medical organizations, public and private practitioners, so that they are aware about the new revised technology national guideline for PMTCT, syphilis, and HIV.
Thank you very much, Dr. Anita. Dr. Anita, thank you so much.
Thank you.
Thank you very much. Now, without further ado, because of the limited time, I would like to invite our next presenter, Dr. Ikachi. He's a medical doctor and Deputy Director General, Department of Health in Thailand. Dr. Ikachi has held several director positions in the government and led projects, including the project on community-based long-term care at sub-district level in Thailand from 2016 to 2021, and the project on long-term care service development for the frail, elderly, and other vulnerable people in cooperation with JICA. He has also supported research on elderly and vulnerable population. And so without delay, I would like to warmly welcome Dr. Ikachi. I'd like to remind our participants to put their questions or comments in the chat box, and kindly remind our guest speaker to adhere to the time. Thank you very much. Over to you, Dr. Ikachi.
Good afternoon, everyone. Now, I would like to talk about the EMTCT program in Thailand. Next slide, please. In Thailand, PMTCT project started in 1993, when we have the first case of pregnant women living with HIV. And now we follow concept from WHO for prongs approach, including primary prevention of HIV infection, prevention of unintended pregnancies among the women living with HIV, prevention of HIV transmission from women living with HIV to their infants, and provision of treatment, care, and support to women living with HIV and their infants and their families. Next slide, please. Thailand implement prong 1, work in younger studying age teenager by provide education in school. Prong 2, focus in reproductive health, planning safe pregnancy. And prong 3, prevention of mother-to-child HIV transmission. And prong 4, for ongoing care for HIV positive liver to care and treatment. Next slide, please. In the system and program, Thailand has developed a long 30 years journey. For example, voluntary counseling and testing. We started for individual, but now we promote for couple HIV counseling and testing. And also antiretroviral therapy. We start only AZT as 34 weeks and add nevirapine, one dose then. And now we provide highly active antiretroviral therapy, SAART, include TDF, 3TC and DTG, and if pregnant woman registers late at ANC, we add raltegravir. And in infant who born from the HIV positive pregnant women will receive ART and provide formula milk until 18 months. And early infant diagnosis by DNA HIV PCR we perform at the birth and at the age of first month, second month, and at the fourth month of baby. Next slide, please. We provide national policy and implementation policy for all hospitals in Thailand. For example, we have the policy to offer HAART for all HIV-infected pregnant women since in the year of 2010. And in the same year, we also have the policy about the couple counseling developed in October at that year and now being implemented nationally. And also EID policy implemented in the same year with a PCR test. And before it was ELISA-based test at 12 and 18 months. And also the policy emphasized on the strengthening monitoring system with the program PIMS version 3.1. And the last one is policy about the formula milk for every baby that was born from the HIV-infected mother. Next slide. Yeah. And we set standard PMTCT program include HIV counseling and testing, laboratory testing for HIV-infected pregnant women, HAART for all, and all pregnant women and husband or partner will receive couple counseling and voluntary HIV testing. Pregnant women with HIV will receive CD4 test and HAART, and the babies born to women with HIV receive the antiretroviral after birth, infant formula, and early infant diagnosis, HIV testing. Next slide, please. This slide talk about the integration and strengthen in maternal and child health standard. For example, promote early antenatal care initiation before 12 weeks among the pregnant women through the hospital and health promoting hospital and community health volunteers, and to motivate volunteers in village to seek for pregnant women for early antenatal care initiation by using incentive or certificates. And also we encourage the couple counseling for HIV testing and strengthen HIV testing service system for faster test results and early treatment. And also to strengthen HIV care and treatment system for better adherence. Next slide, please. And this slide, I would like to talk about the key factors of successful of this project. When we focus on the policy and strategy, the keywords that high national, subnational, and local government commitment. We have the universal health coverage with domestic financing. And also Thailand have the comprehensive national guidelines, and also having the strong monitoring and evaluation system. And funding is very important when we talk about a successful story in Thailand. Thai population largely were supported through the Universal Coverage Program, through the domestic financing. And for the non-Thai populations, we utilize a combination of mechanisms to support PMTCT healthcare costs. And we have the package of HIV services comprehensively funded. And next slide, please. Yeah, talking about the human resources, Thailand have the comprehensive PMTCT network for service delivery, extends from the national, regional, provincial, district, and also sub-district levels. And also, we have the adequate skilled and motivated staff available for ANC hospitals delivery and ART clinics, and having the training program supporting the quality of MCH and the MTCT services. Next slide, please. Talking about the human rights, and this is very important too. We ensure the availability, accessibility, and quality of PMTCT services, respect dignity, privacy, and autonomy, informed consent, sexual and reproductive health rights, confidentiality, and non-discrimination in access to ANC care. Next slide, please. And this is also additional topic talking about the sexual and reproductive health rights, including information on HIV prevention, contraception, family planning. And when we focus on the confidentiality, we have the strict hospitals protocols for maintaining confidentiality for HIV status, and for the non-discrimination in access to ANC care for Thai population, the healthcare system based on the universal coverage works very well, cover all aspects of PMTCT healthcare access. Next slide, please. And access to the PMTCT services for vulnerable groups. Undocumented, unregistered pregnant HIV positive women don't have health coverage before and after pregnancy unless they purchase migrant health insurance. And ethnic groups can experience language and cultural barriers when access care, and female injecting drug user experience stigma and discrimination in smaller hospitals and clinics. And in these 2 or 3 years, we also emphasize on this vulnerable group. In conclusion of the success and sustainability of EMTCT of HIV and syphilis in Thailand include national ownership and leadership, sustained political commitment, a favorable legal and policy environment, a well-developed national health system, the consistent strengthening of its building blocks, enhancing of community systems, and lastly, the strengthening of community interface with health systems. Next slide, please. And this is the results of impact indicators from the year of 2016 to 2019. We still achieve for the all of the indicators, but in my concern, we look at the indicators number 3, annual rate of congenital syphilis per 100,000 live births. The indicators look increased dramatically in 2019. So this is a challenge for Thailand in this year and next year. Next slide, please. This is the picture that when the Thailand has been certified the validification of mother-to-child transmission of HIV syphilis by WHO in 2015. Maybe the second country follow the Cuba. Next slide. Next slide, please. Yeah, and in the World AIDS Day, at that time we kicked off to stop new infection toward the elimination of HIV infection among newborn. And I think this photo is maybe 5 years ago. Thank you very much for your attention. Thank you.
Thank you very much, Dr. Ekachi. And the next presenter I would like to introduce is Ms. Marinda. She is the founder chairwoman of the Positive Indonesia Network, the national network for people living with HIV in Indonesia. As a TB survivor, Marinda also serves a community delegation at the Stop TB Partnership Global and is an active member of the steering committee of the TB Women Global Organization. She has been championing for quality HIV and TB services for 18 years, beginning her journal as an outreach worker for female sex workers. A very warm welcome to Ms. Marinda. Over to you.
Thank you so much, Dr. Salwa. So good afternoon, everyone. So today I will be sharing a brief review on the EMTCT in Indonesia. Next slide. So prior to going into our study findings, let us delve into the importance of eliminations of EMTCT in this country. So according to the Q2 report from Ministry of Health, out of the 834 pregnant women with HIV recorded, only 47% are on ERT, whilst only less than 10% of their infants are being tested for HIV. So there is still a huge gap between the number of tests being conducted and the risk of mother-to-child transmission remains high, seeing as more than half of the respondents are not on ERT. Next slide. So to assess our country's progress, we conducted 2 studies supported by UNFPA Indonesia, looking at different angles or factors surrounding the topic. So we namely the study of preparedness of Indonesia to eliminate of mother-to-child transmissions of HIV through community perspective, and the study of knowledge and perspective of women living with HIV in Indonesia to the elimination program to mother-to-child transmission of HIV, syphilis, and hepatitis B. Next slide. In order to capture the complexity of this issue, we adopted a formative cross-sectional approach to conduct this study, where we collected quantitative data from online survey, qualitative data from focus group discussions and in-depth interviews, as well as supplementary data from desk review, the detail of which are as follows. Next slide. After analyzing results from the online survey, we've seen that although the 342 respondents were somewhat distributed across the provinces, most hailed from DKI Jakarta. And among these women living with HIV, over half were between the ages of 31 and 40 years, and 95% were not pregnant. As for their educational background, 56% have passed senior high. Next slide. The first step we took during the online survey was to identify respondents who have accessed EMTCT services. Once we have identified, say, 283 respondents, we inquired which services they've had experience with. The 3 most accessed services thus far were viral load test, ERV treatment, and HIV tests, with the least accessed ones being gender-based violence services, violence counseling, hormonal therapy, mental health services, as well as syphilis and hepatitis B treatment. Over 85% of the respondents claimed they were either satisfied or very satisfied with both the implementations and completeness of the EMTCT program they received. Upon further inquiry at the in-depth interview, we found that respondents felt the health workers or services were friendly or inclusive, even though some still face stigma and discrimination, such as a disclosure of their HIV status. Next slide. So it was clear that nearly all of the respondents felt the need for support from both community and NGOs to aid the EMTCT and to assist with HIV, syphilis, and hepatitis B treatment or therapy. Albeit a seemingly large barrier, we have actually found that COVID-19 does not significantly inhibit women living with HIV from accessing EMTCT services, bearing the fact that operational hours and human resources or number of health workers have significantly been impacted during the pandemic. On a positive note, nearly 90% of our respondents are optimistic that the EMTCT can be achieved by 2022 or 2023. Needless to say, there are still several factors that need to be addressed in a national program, such as the protection and advocacy of SRHR surrounding contraceptions and pregnancy, among others. Next slide. Aside from gaining insight on the respondents' experience with the EMTCT and felt need and perception related to the program, we also tested their knowledge on EMTCT to see if further educational campaigns or activities are needed at the national level. The results show that over 75% of the respondents had adequate knowledge on HIV, STI, and hepatitis B transmission. On another note, 60% of said respondents felt they are at risk and vulnerable for the transmission. Next slide. Upon conducting our cross-sectional study, so we have identified several gaps and barriers that should be addressed in future EMTCT program. Firstly, it is pertinent that EMTCT services follow the established guidelines and SOPs, which should highlight the protections of women living with HIV's rights. Meaningful engagement of people living with HIV in EMTCT activities at the site level and in the development of policy also need to be further amplified. This relates to the need for strengthened coordination between health facilities and communities supporting women living with HIV. With the persisting occurrence of violations to women living with HIV's rights, such as those in relations to their SRHR, it is urgent that we create preventive measures and address such violations promptly. In relation, it is also important for other social issues such as gender-based violence, coercion, stigma, and discrimination to be addressed through health promotion. Lastly, to achieve the eliminations of mother-to-child transmission, it is also important to increase educational materials and programs for women living with HIV and also for the general public. Next slide. I think this is the last slide. So we really hope that our study in EMTCT ignites further conversations and highlights the need for strengthened activities and coordination between stakeholders and women living with HIV communities. And last but not least, I would like to acknowledge our deep thank you to UNFPA Indonesia that has supported us during this study. Over to you.
Thank you very much, Ms. Marinda. And then I would like to introduce the next speaker, Ms. Prensi. She is the Executive Director of the Positive Women's Network in Sri Lanka and represents the network of women living with HIV. In Sri Lanka, she was diagnosed with HIV in 2001 and started ART in 2005. She is healthy and happy about her life and has a wonderful family support. She has received many awards and Red Ribbon Award in 2012 for her community work helping women living with HIV facing difficulties and challenges. Welcome, a warm welcome to Ms. Prensi, and over to you. Thank you.
Thank you. Good afternoon, madam. I represent the network of women with HIV in Sri Lanka. I am the president of organization Positive Women Network. I was diagnosed with HIV in 2001. In Sri Lanka, we get all services free for HIV. ART was started in 2004. I started ART in 2005. I get all my drugs and blood testing free. I get my viral load and CD4 count annually. I am healthy and happy about my life. I have family support. I am a leader of PLHIV. I received many awards and Red Ribbon Award in 2012 for my work for the community. We started Positive Women Network in 2009-6. Since then, we have helped many women living with HIV. We ourselves are partner of women living with HIV community, and we know the difficulty and women are facing. We work closely with the National HIV/AIDS Control Program of Sri Lanka since 2001, Positive Women Network, and other PLHIV organizations are members of the national organization. Members of national organization, members of national organization, members of the National AIDS Committee and HIV Care Subcommittee. We meet NSCP consultant regularly and meeting. We learned about the EMTC of HIV and syphilis program in 2013. There was a meeting for PLHIV and key population organization. Consultant explained the importance of EMTCT program. They wanted our support. I am a mother of two children. Fortunately, my children are not infected. All of I has agreed to our best to elimination mother to child transmission of HIV and syphilis. First hearings committee for EMTCT was formed. We were members of the steering committee. We sat together and planned program. Our target was to increase coverage of HIV, VDRL, U19. Our target was to increase coverage on HIV AIDS, HIV VDRL, 5 cents in 2016. Our main target was to support the pregnant women with HIV. We supported pregnant women for hospital visit, supported pregnant women for hospital visitors. Partner problem and financially by in 2007. We get ready for validation from WHO, UNAIDS and UNAIDS and working group. Our former we were members of the Human Rights Working Group and looked at the laws and policies, stigma discrimination. We support to field assessment tools, educated PLHIV and key population on EMTCT services, increase awareness and link women with HIV for family planning services. We collected milk powder of NGO and sent to women in remote areas. In 2009, EMTCT program was assessed by WHO. The team visited our office. We told we support the EMTCT program. We received certificate. We work together and work hard. We feel happy as our children are free from HIV. This is success of our collected efforts. I am very proud of our women community contribution in this success. Thank you.
Thank you very much, Ms. Princey, for sharing your extraordinary story. I'm sorry, I really apologize, participants, but given to the short time, we will not be able to take the questions. We will not be able to present the questions to the presenters. Rather, these questions will be addressed and will be shared with you. And I hand over back to my colleague, dear Dr. Yeyu. Over to you. Thank you very much.
Thank you.
Thanks, Sewa. This is very nice session, very well moderated. And thanks to all the distinguished speakers and presenters for your great presentation. We are sorry that we have a little bit time limitation, so we cannot take the question and answer, but we will do follow up with you guys on the respective questions that you can address. Thank you so much. So with that, now I will transfer this floor to our regional director, Mr. Taufik Baghali, for his for his closing remark.
Great, thanks so much, Yeyu. Congratulations to you and to the whole team. Yeah, what a moving stories. It's all about making successful human stories like the ones we just heard. This gathering really showcased the strong partnership between all different stakeholders under the leadership of governments who are implementing and leading the programs, the strong support and contributions from the UN agencies and other partners, and also the very strong engagement and leadership from communities who are making that big difference in the life of people. And this is all done to hear stories like what we have just heard right now. People who have managed to get children safely, safe from infection of HIV. We want to make no more infections for children, among children, a reality in our region. I would like to acknowledge and thank my colleagues and many friends I have seen today in this gathering. Dr. Suman, Dr. Tawhidul Islam, nice to see you after a couple of years. Dr. Basil, and also my dear colleague and friend, Dr. Lin Ville and Dr. Salma, nice to meet you again. I would not skip also acknowledging the excellent contributions. Dr. Ailing, Dr. Shobini, Dr. Anita, Dr. Ekashai, really nice stories. Nice to meet you again. We do hope that next time we get the opportunities to meet in person and get out of the zombieism that is created by the Zoom. But I would not skip acknowledging Merinda and Miss Princey. Merinda, we have met several years before, and so pleased to see you again. Thank you for great contributions and showing the results of the study you are leading. This is the kind of contribution we expect from community leaders like you. I would not extend any longer. Great thanks to everyone who have contributed in various ways to this very successful event. The Data Hub at the end is a resource for everyone. Please access it, contribute to it, send information, send reports, send data, and also feel free to access data and reach out to us, the Data Hub team, if you need any additional information. Or links to any contacts as needed. Thank you so much for your time. And we will close the session here and we'll continue discussions offline after this. Thank you again. And thanks to the facilitators who managed the stream online on Facebook and the Data Hub pages and all these things. Thank you again. Have a nice evening.
Thanks, Taufik, for your closing remark. And with that, I will close this regional webinar for EMTCT. I hope you all enjoy the presentations and the knowledge shared by our participants and presenters. And we hope to see you guys later. Thank you.